So that leads to one of the questions, who all needs to be consulted when you're building these models? You've got the partner coming to you, propose a payer, employer, but it sounds like you're also consulting your clinicians, probably folks here on the administrative floor as well. So who needs to be in the room when you're developing a model?
When we include our primary care leadership and some of our specialist physicians that are in leadership positions on our contracting meetings, so that we know what our contracting team is having discussions with our payers to say, is this something that makes sense? As a provider, I raise my hand and say, guys, I don't know that this makes sense, or I'm worried that we will not be able to perform on this metric because of X, Y, and Z. And so we have that voice to raise those concerns, and I think that's really important. In that as well, and these meetings that we have our operations folks that are the ones that have to make it happen within the clinics, but also keeping in mind it's not all primary care that's driving the total cost of care, and so having our specialty counterparts understand these types of arrangements and what they can do to help us be successful.
So do you ask them to come to this table as you're designing an approach for a given payer? How do those people get to the table? Do they elect them themselves or what?
Mercy, we have section chairs for different specialists, and we have specialty councils as well for the entire system. And because we have regular meetings as a group, as a clinic group, all of those voices are already there. So there's different ways that our physician leaders get to those places. Sometimes they're identified by a leader already in Mercy and they are asked to serve and they volunteer. Others are raising their hand and sort of wanting to be more active in administrative space. But Mercy, we view ourselves as physician-led, professionally managed. So at almost every level of leadership within Mercy, there's a physician and administrative dyad that work closely together.
I'm glad you brought in the administration as part of that dyad. You mentioned finance earlier. So how is the voice incorporated from the folks in finance, the hospital leadership, because we've really focused our conversation on the clinicians, especially primary care. Mm-hmm. What about that? Because if you do your jobs too well, don't they lose a lot of money?
Well, so that was often the conversation when I would talk to employers. Honestly, many of them were skeptical about us saying, hey, we want to do this with you, we want to partner. Oh, sure, you're just going to drive more care into your hospitals at my expense. But really what happens when you start entering into this process is you hope to expand your patient base. You'll always need hospitals. You'll always have procedures that need to be done. You hope to decrease the number of procedures within a defined set of population, but as you expand the number of patients that call you their provider of choice, then you shouldn't have to worry about some of those decrease in procedures and those types of things that happen.